Thank you, Andrea. That was world class. Many of you will recall that many of our survivors spoke very passionately and, to be honest, very painfully about their experiences of the impact of their treatment on sexual function and their sexual lives. So we are very fortunate to have with us Dr. Nicole Noyes, who is a world-renowned expert in issues pertaining to fertility and these related issues. So I'm delighted to hand the podium over to Dr. Noyes. Thank you so much for joining us. Thank you.
Good afternoon. It's funny to be at a colorectal conference. I'm an obstetrician. I'm not. I'm just a gynecologist, but I wanted to be a cancer doctor. I came to New York to go to Sloan Kettering. I went to Cornell for residency. I was sure I was going to be a GYN oncologist, and somehow I became a fertility doctor. And in the process of doing that, I gravitated back toward oncology through becoming a fertility preservationist for patients with cancer. And we've only been freezing eggs routinely since 2005, so it's a pretty new discipline, and it's been a very exciting run. Just looking at the age of the age distribution of colon cancer, I'm sure you're all aware more than I was, but when I looked at this, I was surprised that it was just a perfectly shaped male-female distribution. But when you look at the patients that I would see, it's only about 2,000 of the patients, and really for fertility, it's under 40, so it's only about 1,100 of these patients. So it's not that many, but I have to say I've seen a fair amount of patients with colon and rectal cancer in reproductive age. So I would say New York physicians are doing a good job with this. I've only had one of those patients die since then, so I feel like it's been a very positive run so far. And as you've all expressed and know more than I do, young age colon cancer is on the rise. So this is something that we definitely have to pay attention to. I'm going to switch gears and talk about fertility now. And if you look at the US birth rate, it's the lowest it's been in 30 years. So if you look, in 2018, there are 61 million women of reproductive age, and there are about 3.8 million births. So I calculated what someone said before about the incidence in pregnancy, so it would be about 300 cancers in pregnancy in the US per year. But if you look at that in a graph, and you look from 2005 to 2017, and look at the birth rate and the number of births, look what's happening. It's dropping pretty significantly, actually. So the birth rate decline is in women age 15 to 34, and the only rise is in women age 35 to 44. So looking at the graph at the bottom of the slide, it's a little hard to see because there's lights on me, so I'm going to move over here. But if you look at the graph on the bottom of the slides, you see that this is the rate of births per 1,000 women. And if you look at women from age 20 to about age 35, you see there isn't much change. It's kind of flat. But then if you really focus at the end, you see it is actually going down a little bit just in the last couple of years. If you look at the teenage years, that's where we see a big drop. And you say, well, that's great. And I do think it's great. But if you look at reproductive prime, it's age 16 to 28. So human females are meant to have children from 16 to 28. And I can remember being 6 years old. I'm one of 7 kids, 4 sisters, so 5 women lined up like this. And my dad said, if any of you get pregnant, you're going to a wayward home. Okay, that was my sex education as a child. And luckily I'm here, and I had 3 children, married, the whole thing. But I had no idea what that meant. But I'm just saying that in the 60s and 70s, there wasn't a lot of sex ed, and really it's the internet that has gotten that message out. So listening to what you were all saying before, I think just getting the message out on Instagram and things. I was meeting yesterday with the PR people about getting fertility information out in general, and it's just amazing how many people you can reach with Instagram, Facebook, and et cetera. But anyway, in teenagers, it's gone from 70 per 1,000 in 1990 to 17 per 1,000. That's pretty amazing. That's remarkable. If you look at 35 to 39 and 40 to 44, you see they're rising. But the general fertility rate is only 60 in 1,000. So the general fertility rate today is lower than the teenage rate was in 1990. Just, something to keep in mind. The total number of births is 1765 per thousand. So on average, women are having less than 2 children. Okay, again, I'm one of 7. And there are in women over 50 years old, there were 850 births in 217. So the shift is later and less. Well, why is that a problem? If you look at the female ovary in a woman from conception to age 40, a fetus has the most eggs. So at 20 weeks in utero, halfway through the pregnancy, a female fetus has 6 to 7 million eggs. That seems ridiculous. First of all, you can't make a single egg after you're born. When we really want to make eggs is from 30 to 40, and we make 6 million at 20 weeks, and we're born with 1 to 2 million. So we spend all this energy making these eggs. Most of them die out before we're born, and then we get to puberty. I mean, it's crazy. I definitely would have designed the female differently. Not that anyone's asked, but if they did. No, at puberty, you're down to 300,000 eggs. So you're down to 15% of your original cohort. And you say, okay, you ovulate from 12 to 50. That's about 38 years, 12 months, 450 eggs. So you only need 450 eggs. So you go, okay, I'm good. But you're not, because what's happening is every month you ovulate, there's a group that's dying out. So dying out every month. And that group gets bigger and bigger as a woman ages. And so from puberty to 30, you're doing okay. You only go from 300,000 to 240,000 eggs, so that's when you're fertile. But from 30 to 40, you go down to 60,000 eggs. And really the big drop is from 35 to 40. So a woman loses about 15% of her fertility each year from 35 to 40. So I think of that as like a tsunami coming through with every ovulation from 35 to 40, so that when women are 40, they're not that fertile anymore. And they think they wake up at 40 and they're not fertile, but actually it's been happening for the 5 years before that. And coincident with that decrease in number is the decrease in quality, so the ability to combine with sperm correctly and have the correct chromosome complement. So that's when women become relatively infertile, and that's when most of your cancer patients are diagnosed. So these trends aren't just in women. So old women aren't marrying teenagers. Men are also waiting to have children. All races, all industrialized countries. And I looked online to see who's the oldest male to have a child. And I found Ramjit Rajav. He was 96 when he had his first child, and 94 when he had his first child, and 96 when he had his second. And I said, he looks pretty good, but I'm not sure he's 96. I just don't believe it looking at that, but he could be. But, you know, he's holding that baby. First of all, the baby's asleep, so anyone who has a baby, you don't keep feeding the baby once they're asleep. And also, when you look at the bottle, the milk, actually, if you look at the slope, it's not actually going into the baby's mouth. So he's busted. That was a shot just for Wikipedia, but anyway. The point of all that is that given the choice, both men and women are delaying childbearing in favor of reproductive autonomy, making more people diagnosed with cancer who have not yet had or completed their family. So that's the serious takeaway, is people are waiting longer, having less kids, and getting diagnosed with cancer and going, what do I do? So, you know, as you all are aware more than I am, you know, all of the treatments that you use can impact fertility. Surgery, because you're operating proximal to where the reproductive organs are, adhesions. Chemotherapy can wash through the ovaries and decrease both the quantity and the quality of eggs. And like someone just pointed out, it's not just whether you have a period. So once one of the fellows and I wrote a paper, menses doesn't equal motherhood. So lots of people think if you're having your period, you're still fertile. But actually, from 40 to 50, women are still having periods, and they're mostly not fertile. So you can't equate having a period with being fertile. There are markers like the AMH, but you know, it's hard to judge ovarian reserve or how the ovaries are doing unless women are using the litmus test of actually having a child. And the last is the radiation, which was also discussed today. And obviously that has ovarian compromise and uterine compromise. And transposition does help when you move the ovaries out of the pelvis, but when you move the ovaries out of the pelvis, it makes the women less fertile. One, because you're stretching that blood supply to the ovary, and two, you're moving the ovary and tube away from the uterus, and it just makes it harder to get pregnant naturally, so often you need fertility preservation. With the uterus, I know it was just mentioned that you can do uterine transplantation, but that's a long way from now. I mean, there has been a birth in a uterine transplantation, but it's tricky, and if you've radiated that area, your blood supply is going to be compromised, and pregnancy is such a a vascular event, that wouldn't be my first choice. I'd go with gestational carrier. So she just gave me a minute, so you're gonna learn everything I know in 1 minute. So here's your options. If you take the ovary and the uterus, you can stimulate the woman's ovaries and mature oocytes. You can stimulate the ovary and retrieve mature oocytes and put them with sperm and have embryos. You can take ovarian tissue out and freeze the tissue and put it back in once the patient is cured. You can transpose the ovaries, and you can always use the eggs of a donor, so a younger donor, or not even necessarily younger if it's a young patient, but the eggs of someone else when you're ready to have children. And you can do donor egg, donor sperm in a gestational carrier. There are really very few restrictions in the US about reproduction. I won't really go into the factors, but basically, I've treated everything short of somebody on a respirator in the ICU. I mean, there's a lot of patients who, some patients have 5,000 platelets. I mean, as long as they're healthy enough to go through the procedure, I feel comfortable treating them if I think they have a real shot at living and using the eggs. And partnership status is really if whether they have a partner or not. Some people want to freeze eggs rather than embryos just so they have the reproductive autonomy as an option later. Some people freeze both eggs and embryos. But it's important to, in my mind, when I see the patients, to avoid unnecessary intervention or procedures of uncertain benefit in unwell patients at the time of extreme stress. So I know these patients are often extremely stressed and scared. And so I try to be practical, and that there's more than one option for a given patient, and you really have to individualize based on what's going on. I'm not really going to go into the transposition because she discussed it a little bit. I'll talk a little bit about ovarian tissue cryopreservation. It's something you can do at the time of the colon surgery, so it's easy to take out the tissue. It's pretty easy to freeze the tissue. It's pretty easy to put the tissue back into the pelvis. It can be done quickly. The most important takeaway is there hasn't been a birth under the age of 13 years and 11 months. So even though they say this is the only treatment available for prepubertal girls, there has not yet been a birth putting transplanted tissue back into a woman who has frozen before the age of 13 years, 11 months. And the oldest woman that they put it back in and there's been a baby is 36. So this is really for the prime reproductive age. And if you look at the graph, I don't know how well you can see it there, but there's about 100 births in the world right now from ovarian tissue transplantation. So it's not up to, it's not beyond the experimental designation at this point. That affects insurance coverage. I'm going to talk a little bit about embryo cryopreservation, just that there are about 1 million births at this point. It has about the same success as in vitro fertilization with fresh eggs now, pretty similar. This is 40,000 frozen embryos that were transferred. There are also donated eggs and donated embryos. There were 1,200 donated embryo cycles in 2017. So people are actually donating their embryos when they're finished having children, and these can become available to your patients. Oocyte freezing, I said it became mainstream in 2004. That's true. The first birth was in 1986, but it was really hard to reproduce that first recipe that was published. The difficulty is that the egg is about 100 microns, and it's 80% water. So it's really hard to freeze something that has important proteins, the spindle, the meiotic spindle, loaning up, something that's very important for lining up the chromosomes within that water. And it was just really hard. Basically, things would crack and get ruined. If you take an egg from body temperature down to 0 degrees over 10 minutes without any cryoprotectants, any dehydration protocol, what you'll see happen is, I don't know which one of these is the laser. Oh, here we go. Yeah, you'll see the microtubules and chromosomes just totally disperse over 10 minutes. So you have to be very careful with eggs, and that's why it took so long. But now there are precise dehydration protocols, and we are able to successfully freeze and thaw and create birth from frozen eggs. The advantage, really, the biggest advantage is reproductive autonomy. The live births that have been reported, there's no increase in birth defects. There are about 8,000 births now, so it's not considered experimental anymore since 2012. And we've even looked at cancer patients, and there's no difference in the eggs or the egg quality that are retrieved, even in that stressful cancer-ridden state. When we look at live births from egg freezing, They are definitely improving, and they're approaching IVF. This is, by age, about 40% in younger patients per time you put these embryos back into the uterus. And if you look at frozen embryo transfers, it's pretty similar. The caveat is that embryos are twice as efficient as eggs, meaning we have a lot of attrition from when we take those eggs out of the body to when we put them back in the body. There's a lot of attrition, and I'm not going to go into that, but basically I think 2 eggs equals 1 embryo. So if there aren't going to be a lot of eggs, then and there is a partner, then I really push toward embryo than eggs. This is my last slide. So the last thing I wanted to say is that we've written up the cases. I've frozen eggs for more than 250 patients, and 10 have come back with 12 embryo transfers, and 50% have had babies, so it has been successful. And one of the patients came back recently. She was somebody who had a trophoblastic disease of the uterus, and actually her sister was going to carry for her. She was going to have a hysterectomy, and her sister was going to carry, and the sister backed out. And she decided that she would rather die than not have a child. So we worked it out with the oncologist. We cleaned out the disease as much as possible. We put the embryo in. She had her son, and she just came back 3 years later, and now she's going to use a gestational carrier for another child. So she did survive her disease. So in summary, cancer care is no longer defined simply by eradication of disease, but now includes addressing quality of life issues such as parenthood. If treatment of a disease process impacts gynecologic organ function, fertility-sparing procedures and fertility preservation should be considered when possible. Third-party and even posthumous reproduction may be part of the equation and should be addressed early because they might be deal breakers. And of all the fertility preservation options available to women, those with the widest application are embryo and oocyte cryopreservation. Thank you.